Hello, I'm Mark Gurnell and I'm based in Cambridge in the UK. And the topic of this talk is looking at laboratory variations in thyroid function and some of the pitfalls that can present to us when trying to solve cases presenting with unusual thyroid function tests. So I've got no relevant disclosures. So I'm going to begin by just highlighting where some of the traps or pitfalls for the unwary lie. And I think it's often easiest when thinking about thyroid function tests to think of those that might be related to a pre-laboratory factor. And that can sometimes reflect on the fact that perhaps we haven't paid quite sufficient attention to the clinical context. So we know that reference ranges can vary for thyroid function tests depending on age. We need to think about things such as pregnancy changes, potential confounding effects of other medications, or indeed thyroxine replacement therapy itself. And then also other potential interference in our interpretation, for example, due to the presence of non-thyroidal illness. The next category are the problems that occur from a laboratory. Now, it may be nothing to do with the laboratory's performance of the test, but there may be something about a limitation of a particular assay. And in particular, we need to consider assay interference due to a variety of different antibodies and also genetic disorders. And then also in the post-laboratory setting, it may be that the condition we're dealing with is a rare genetic or acquired disorder of the hypothalamic pituitary thyroid axis. And it may be that our own personal experience of these conditions is relatively limited and that we need to seek specialist advice. And we're going to use a series of cases here to illustrate these different points. So I'm going to begin with case one, which is a 72-year-old gentleman who was referred to my service by his primary care physician. This gentleman actually had a progressively rising TSH level, been on long-term thyroxine therapy, and the GP was a little perplexed as to what was going on and asked if we could see and advise. So you can see that he'd been on thyroxine somewhere between 125 to 150 micrograms a day since a diagnosis of primary hypothyroidism many years earlier. And he was having simple annual TSH monitoring, which had been unremarkable until recently. Now, when his past medical history was checked, he was noted to have hypertension and a mechanical aortic valve, and that explained his current medications, which are a combination of furosemide, lisinopril, simvastatin, thyroxine, and warfarin. There's nothing else of note. From a clinical perspective, when he was seen in our clinic, his heart rate was 96 beats per minute, sinus rhythm. Blood pressure was 140/85. There was no palpable thyroid gland at this stage and nothing else of note. But herein lies the problem. So for all results that you'll see presented throughout the cases here, any of the normal results are shown in gray, and you can see the relevant reference ranges relating to each parameter. Anything which is raised will be shown in red, and anything which is low will be shown in blue. So this patient actually went on to have repeat thyroid function tests by his GP, which actually demonstrated, if anything, a slightly higher TSH, and if anything, a slightly lower free T4. So the question here is, why is the TSH rising despite what has previously been an adequate level of thyroxine replacement? And the question is, what should be done next in this situation? Well, in actual fact, I think a really important thing to do here is to go back and look at those previous thyroid function tests. And we were actually fortunate enough to be able to retrieve thyroid function tests dating back around about 5 years. We can see that actually when the patient was first commenced on thyroxine, possibly a slight degree of over-replacement, producing a slight down titration of T4 to, the levothyroxine to 125 micrograms a day. And then that kept things pretty stable until that up-to-date sets of bloods that were done, separated by 2 months, seemed to indicate that at this stage that replacement was no longer adequate. However, even though the thyroxine dose was up-titrated, you can see that the biochemistry continued to show an escalation of the TSH level, actually rising eventually to above 50 milliliters per liter. You can also see the T4 response to this, in that the T4 level is also now rising, so eventually exceeding the upper limit of the reference range. So the question is, what should you do next? What is the cause of the abnormal TFTs that we're seeing? Because now we have a patient with hypothyroxemia with non-suppressed TSH. So I think this is a really important figure to always keep in mind when one is faced by unusual thyroid function tests. So in actual fact, at the moment on screen, you can just see the classic patterns of thyroid function tests, normal results, typical thyrotoxic features with the raised free hormones and the low and indeed typically suppressed TSH, or in hypothyroidism, low free T4 and free T3 with a clearly raised TSH. But there are unusual patterns, which I think are always worth holding in mind, the potential causes thereof. So we may have normal thyroid hormone levels, but with a low TSH or a suppressed TSH. And here are some of the conditions that might be associated with that, the classic one being subclinical hypothyroidism. Alternatively, the free thyroid hormone levels may be normal, but the TSH is raised. And again, here are some of the potential conditions that can be associated with that, including, for example, subclinical hypothyroidism. For completeness, over here, I'm just showing patterns of results where we have low free T4, free T3 levels and where the TSH is inappropriately normal or indeed low, or raised free T4 and raised free T3, where again, we can see that the TSH has not shown the expected result. If anything, we can see the TSH is actually normal, or alternatively, is actually raised. And here again, there's a whole list of different conditions. So we just think about the patient that we presented a moment ago, whose TSH level was rising, initially with a normal T4, but in whom eventually the T4 level itself was also raised. We're now considering conditions that lie initially in this quadrant over here, normal T4, T3, raised TSH, or eventually have migrated with the supervision of the thyroxine dose to raise T4 and T3, again with a non-suppressed, and in this case, quite significantly raised TSH. And so I'm sure that as you glance at this picture, you can see that there are some conditions which actually cross into both these territories. So there's a whole number of conditions that we can exclude as being less likely, and there are some conditions which now look more likely. And in particular, we need to think about the possibility that either there's an issue with compliance with thyroxine with this patient, or that there is a problem with how we are measuring either the free T3, free T4, or indeed the TSH itself. So in fact, in this case, the first thing that we did was to actually send the sample to measurement in 2 laboratories. And we checked the thyroid function tests in the original laboratory, which had generated the abnormal results, but also on a second platform. So this is the same blood sample sent in 2 directions. And the most important thing is that you can see that it highlights that the free T4 levels are comparable between those 2 platforms, but there is a huge difference in the TSH levels. And in fact, this pattern of results on platform 2 with the raised free T4 and the suppressed TSH now on this high dose of thyroxine were compatible with the patient at this stage who had developed palpitations, weight loss, and difficulty sleeping at night. And that tells us that it's these initial sets of thyroid function tests which are likely to be the confounded or unreliable results, in particular, the TSH. How does this happen? Well, it's important that we remind ourselves of how we measure analytes such as TSH. This is done using a conventional sandwich assay. So in essence, the analyte, the TSH, is immobilized through a capture antibody. In this particular schematic, it's shown on a plate, but actually more commonly in most assays, it's now, for example, a bead. So there's an antibody to which the analyte binds. And then when that's immobilized and the remainder of the serum sample has been removed, we have the detection antibody, which actually allows us to actually generate the signal, in this case, immunofluorescence. So we only get signal when there is the sandwich filling joining the capture and the detection antibodies. How can this type of assay get perturbed? Well, it can be perturbed by the presence of something in there which can form an artificial bridge between the capture and the detection antibodies, even if the analyte is absent. And the most common is an antibody which is cross-linking. So this is an antibody in the patient's serum. This would be either a heterophile or potentially an anti-animal immunoglobulin, which is able to bind those 2 antibodies and therefore give a signal readout from the assay, even though the analyte is absent. Interestingly, the opposite can also happen. We can actually have antibodies which are capable of interfering with the assay by blocking the binding of the analyte either to the capture, as in this case, or it could be blocking the binding to the detection antibody. And that means that even if the analyte is present, there'll be no readout. So this would actually suggest there is no TSH, whereas the paradigm shown in B would suggest there is TSH, even if there isn't. So moving on to another case. This was a 7-year-old boy who was referred after early postnatal screening had detected a very elevated level on the TSH blood spot test. So you can see a result which sounds or looks like profound primary hypothyroidism. Now, interestingly, this was a child born after a normal pregnancy and labor. On close scrutiny, yes, there was some dry skin, possibly mild jaundice, but nothing else of note and no goiter. So here we can see that very abnormal result, which obviously caused significant alarm, but raised TSH and there's no free T4 at that stage. That triggered an early recall blood, and as you can see at this point, the TSH, if anything, is now more strikingly elevated, albeit interestingly with a free T4, which is probably normal, although one has to be careful about giving reference ranges for children of this age. Now, as it happened, the pediatrician who was looking after this young boy decided that actually it would be appropriate to start thyroxine for fear of missing primary hypothyroidism. But on thyroxine, although the TSH did appear to have reduced a little after a week, you can see that actually the free T4 and the free T3 levels are now into what is likely to be a thyrotoxic range. And in fact, the child was now not as well, more jittery and not feeding as well. So the question is, what should be done next? Well, in this case, the question is mum similarly affected? So mum who'd been asymptomatic with no history of thyroid disease, with no goiter, and who was clinically euthyroid, was found to have a very similar pattern of abnormal results with a clearly elevated TSH level, but here with appropriate reference ranges, normal free T4 and normal free T3, and for what it's worth, negative antibody titers. So here is something which is perturbing both mum and the young boy's thyroid function tests in a similar pattern. And this is a different form of laboratory interference. Again, it's a problem with the TSH assay. So again, we have the capture and detection antibody, but in this instance, it's an entity known as macro TSH. Now, macro TSH is very analogous to macroprolactin. So here, there is an immunoglobulin which is targeting TSH, and therefore, in so doing, is preventing its clearance, but is not blocking either of the epitopes which are responsible for the capture or a detection antibody binding site. So it's allowing more TSH to circulate in the blood, but at the same time, it's allowing that TSH to be detected in the assay. Now, importantly, the presence of the macro TSH does prevent this TSH from being biologically active, and that explains why the patients, in this case, the mother and the boy, do not actually have clinical or indeed true biochemical thyrotoxicosis. But of course, it is causing a problem in the assay because this TSH is detectable, and so it's immunologically detectable, but biologically inactive TSH. And I'm just showing briefly some data from very nice studies that suggest actually outside this context, just in the context of looking for patients who've got diagnoses of subclinical hypothyroidism, i.e. isolated elevated TSH with normal free T4 and free T3, and not in significant proportion of adults with this diagnosis, somewhere between 0.5% and 1.5%, actually may have macro TSH rather than subclinical hypothyroidism due to early primary thyroid failure. And so this is actually something which the laboratory can readily solve. And it's certainly something that is worth discussing with the laboratory. So generally, after these first two cases, how do we exclude TSH assay interference? Well, there are 4 real routes we can go. We can perform so-called dilution studies. Now, in a dilution study, we're looking to see whether there is a cross-linking antibody that I showed you earlier in the schematic, such as a heterophilic antibody, which forms a weak cross-link between the capture and detection antibodies and that can be displaced by dilution of the sample. So here is a blood sample of a patient with genuine hypothyroidism with no interference being diluted 1 in 1, 1 in 2, 1 in 4. And you can see that as the dilution occurs, if we then back multiply by the dilution itself, so here 14 times 2 obviously becomes 28, etc., we see a pretty stable TSH calculated measurement after dilution. Here, however, is a patient with classic TSH assay interference due to a heterophilic antibody, whereas we dilute the TSH, that complex falls apart much more easily and readily, and in so doing, we can see that the back multiplication no longer holds true, so the dilution is not steady. Now, this is a good way to do things, but it doesn't exclude always more high affinity antibodies such as anti-animal immunoglobulins. We can also do polyethylene glycol precipitation and then measure the hormones in the supernatant. So that's a way of actually, the same as macroprolactin, pulling down the immunoglobulins so that we actually remove anything which is not actually, so that we actually, shall I say, measure hormone in the absence of the interfering immunoglobulins. We can perform gel filtration chromatography. This is potentially very helpful for macro TSH. Here you can see very nicely the TSH eluting from a column with normal TSH size, whereas here, if the TSH is bound to an immunoglobulin, it comes off the column much later because that's a bigger complex size. And I also showed you in the very first case of this talk, a patient where we actually were able to sort this out just by comparing across assays. But you need to be very, very careful when you simply send a blood sample where you suspect interference to another laboratory and ask them to exclude the assay interference. Because if they use the same platform, or alternatively, if they use a platform that is also susceptible to the same interference, you may get the same wrong result. So simply repeating the measurement in a different laboratory, and if you get the same result, it does not confirm that you have actually definitely excluded assay interference. So let's move on and now look at something a little bit different. So this is a 35-year-old lady who was referred to the clinic with increasing tiredness and lethargy and inability to lose weight. Interestingly, in her past medical history, she'd had palpitations for which no cause was identified, although these were not a problem at this time. She was felt to actually have some possible hypothyroid phases and a bradycardia, but no goiter. But herein is the problematic set of thyroid function tests. You can see the TSH is markedly elevated here, but the free T4 is not low. The free T4 is actually raised. There is, however, a very strongly positive thyroid peroxidase antibody titer, and TSH receptor antibodies, typical of Graves', for example, are not raised in this case. So what should we do next? So something is clearly not correct. We've got raised TSH, but also raised free T4. And here, we chose to try the same first maneuver as we'd shown you in one of those previous earlier cases. We took one blood sample and we sent it to multiple laboratories. And what is very striking is whilst every single laboratory confirmed a TSH suggestive of significant primary hypothyroidism, the free T4 assays in these laboratories return results anywhere between overtly thyrotoxic, as that first assay did, through to apparently euthyroid based on at least free T4 levels here, to frankly overtly hypothyroid. Clearly, this cannot be the case. The single blood sample returning very diverse results across the assays. So this reminds us we just need to think a little bit about what the architecture of a standard T3 and T4 assay, most laboratories, how these are constructed. So T3 and T4 are smaller entities, so it's not possible to do a conventional sandwich assay. So instead, we do something known as a competition assay. So we have a fixed number of binding sites, and these are capture antibodies which are able to bind to either endogenous T3 or T4, whichever assay we're doing, together with a competing analog, a T3 or a T4 analog. We know how many capture sites there are. We know how much of the analog with the label we've put into the assay, and therefore the only variable is the endogenous hormone. And what will happen is the amount of analog that can bind to the antibody will be inversely proportional to the amount of competing endogenous hormone, which is there trying to bind to these same binding sites. So we then add enhancement solution, and if there's a large amount of occupation of these binding sites by endogenous hormone, we will see a little binding of the analog and little, in this case, fluorescent signal. Whereas if there is little endogenous hormone, then we should see lots of binding of the analog. So it's an inverse signal, essentially. Now, normally, when we have no other confounding factors in the background, this assay works pretty robustly. But if we have, for example, variants in the binding protein albumin, which you'll recall is one of the significant binding sites for T3 and T4, or alternatively, if we have antibodies which are capable of binding T3 or T4, these can perturb this assay. They can bind in particular the analogs really nicely. And of course, if the analog is therefore removed from this equilibrium, that will give the impression that actually the binding sites are being occupied by endogenous hormone, and therefore the analog is being excluded. Even if there is little endogenous hormone to truly compete, it just is because the competing analog has been taken out of that equation, as it were. Instead, therefore, we can do a two-step assay where we actually allow the patient's serum to incubate with these binding sites, and we then perform a wash step, and we only introduce the analog when hopefully those variants in albumin or the anti-iothyronine antibodies have been removed, and therefore we're more likely to get a more reliable readout. And in this case, All of the assays that produced the abnormally high or inappropriately apparently normal readings were one-step assays, and the two-step assays were the ones that generated the true indication that this patient really did have primary hypothyroidism compatible with the TSH. So again, this reminds us that the same result in different hands could still be the wrong result. So we need to know what type of assay we're using. The gold standard actually for measuring free T4 and T3 is equilibrium dialysis. Here we actually keep the binding antibodies or interfering binding antibodies or binding proteins on one side of the dialysate membrane. Free T4 and T3 are small enough to cross to the side, and we measure these analytes in the dialysate. And in this patient, we were able to show that the patient had profound hypothyroidism. This turned out not to be due to a variation in the binding proteins, a condition called familial dysalbuminemic hypothyroxanemia, but instead was due to the presence of antibodies against iodothionine, which were therefore perturbing the assay. So this patient had a diagnosis of primary autoimmune hypothyroidism and free T4 assay interference. Just to remind you that the differential diagnosis for that is familial dysalbuminemic hypothyroxanemia. This is where we actually have a mutation in the albumin gene. Recall that albumin is actually an important binding site for both T4 and T3. So we have 4 potential binding sites for each of those within albumin. And if we actually look into one of these pockets where we can see normally T4 or T3 binding, we can see some very key residues lining the binding pocket. And the side chains of these key residues are displaced once the T4 and the T3 occupy these binding sites. What happens in FDH, familial dysalbuminemic hypothyroxanemia, is that one or more of these side chains are mutated, and that side chain mutation results in a more accommodating pocket for the ligand. So it's easier for the T4 or T3 to bind. And therefore, it's also easier for the analog to bind, and therefore we can perturb that equilibrium in that assay more. This can be really dramatic, and we've actually even seen cases recently where variations in albumin don't just cause problems in thyroid hormone assays, but also cause problems in other assays, such as, for example, the cortisol assay as well. So I'm afraid the story evolves a little further. For a long time, we thought that actually the two-step assays were relatively immune to interference by FDH, but I'm afraid here, looking at blood samples run in different assays from multiple members of different families, we've unfortunately shown that actually this is not a problem just for one-step assays, but it can also affect some of the two-step assays as well, so that even those can produce abnormal results. And therefore, one needs to be very aware of this possibility, and a high index of suspicion is necessary. And if you can't resolve this, and it may well require referral to a specialist laboratory who hopefully will have access to equilibrium dialysis. Okay, moving on to another case. This is a 22-year-old man who was referred with symptoms suggestive of thyrotoxicosis. He had nothing of note in his past medical history and clinically appeared to be euthyroid. But he had raised free T4, raised total T4, but a TSH which was normal. So the question is, which results are abnormal? And I guess he's got symptoms that suggest the free T4 and total T4 may be correct and the TSH is wrong, but the clinical examination fits more with the normal TSH and requires explanation of the T4 levels. He did not have a variation in albumin, so the FDH screen was negative. However, he has a variation in another one of the binding proteins. So you remember that thyroid hormones are bound to TBG, also to albumin and to transthyretin. And we now recognize that there is a mirror condition almost of FDH, although it produces slightly different abnormal thyroid function tests called dystransthyretinemic hypothyroxanemia. And here we can see variations in the transthyretin gene, which produce similar issues when it comes to the assays that we're running. So I simply mentioned this briefly to highlight that there's another potential binding protein abnormality. Now remember, both DTTRH and also FDH are truly genetic disorders, but their consequence is only that they disturb laboratory assay measurements. So these are patients in whom the important thing is to make the diagnosis so that then any future thyroid function tests can be measured on platforms that are not subject to interference. Again, you can see here that when this patient's blood was sent to different laboratories and different platforms, you can get widely differing results. And in fact, only one of the platforms really confirmed the true euthyroidism of this patient, which all along had been suggested by the TSH level. And here is a mixture of the two-step and one-step assays, which are misbehaving. So just to summarize at this point, the likelihood of observing interference and the type of interference depends on the type of assay. So whether we're looking at the presence of anti-ida antibodies interfering with T4, or FDH and other binding protein abnormalities interfering with T4 or T3, or is it heterophilic antibodies interfering, for example, with TSH, or today we haven't discussed the possibility of displacement due to non-esterified fatty acids. The pattern of results one gets depends on the type of assay that we're using, be it a one-step assay or a two-step assay, or, for example, equilibrium dialysis. And equilibrium dialysis is generally the gold standard. But if the problem is, for example, displacement, for example, due to high levels of non-esterified fatty acids displacing thyroxine from its binding proteins, then that will still yield a high result in an equilibrium dialysis assay. So moving on now towards the final case. So this is a 2-month-old boy who presented with neonatal seizures. He was feeding normally and gaining weight, although he was very small for size, and actually was found fairly quickly after birth to harbor a significant chromosomal deletion and duplication combination. There were no features to suggest genuine thyrotoxicosis, but he had a very abnormal set of results with raised free T4, raised free T3, and a TSH, which is low, albeit not fully suppressed. And in fact, these blood tests were repeated across several days, and you can see a pattern which suggests really quite alarming free T4 and free T3 levels, a TSH which continues to be low, albeit all measurable on each occasion. And then eventually, when the TSH receptor antibody titer was checked, this was found to be markedly elevated. Interestingly, however, parental TFTs were normal, ultrasound scan of the thyroid was normal, and anti-TPO and TG were negative. So how could this child have what appears to look like Graves' disease, neonatal Graves' disease, with a raised TRAb, raised T4, T3, and low TSH? Probably the clue in here is actually to look at the TSH level, which one might have expected to be truly unmeasurable with this degree of thyrotoxicosis. And in actual fact, this turns out to be another example of laboratory assay interference. So here we see this rather alarming pattern of results, but when we repeat the free T4 and TSH measurements in a separate platform, they are completely normal. And perhaps even more alarmingly, or perhaps reassuringly, depending on which way you're thinking of this from a patient or laboratory perspective, we can see that the TRAb titer is negative in a second independent TSH receptor assay antibody. So these results are all artifactual results. And this is due to interference in the assay by biotin. Now, biotin is used both as a health supplement, but actually it also has specific medical therapy indications. And one of these indications is for inborn errors of metabolism. And that is why this child had been started on biotin. At particularly high doses, biotin has also been used in patients with multiple sclerosis. But individuals with no issues at all sometimes take biotin as a supplement to improve their hair and nails. And here, the problem is an assay which depends on the streptavidin biotin complex for immobilization of the capture antibodies onto a bead. If this complex needs to be allowed to form, i.e. is not preformed, then the presence of biotin floating in the patient's blood can jump in there and block that complex and cause an artificial obstruction of the forming of that, such that actually then, even if the T4 analog comes along, it may not be able to bind properly because there is no space for the interaction between the antibody and the bead. Whereas in a non-susceptible assay, such as one where the antibody is already immobilized to the streptavidin-coated particles so that you cannot get interfering biotin, you do not see that abnormal result. And here is a patient who has got clear interference in the free T4 assay, which is using a streptavidin biotin non-preformed complex and not in an alternative platform. In this case, the TSH assay is robust. And this problem, I'm afraid, can be repeated across many different assays. So you need to be aware of this because it can create merry mayhem in measurements that you make. So Just to briefly remind, age-specific reference ranges, clinical context, thyroxine therapy can also all cause artifactory abnormal thyroid function tests. So don't forget any of these different potential problems when you're interpreting thyroid function tests, because this is how I would then recommend you approach a patient, reevaluate clinical history, think about all the potential confounders that could be interfering with your interpretation of those results. It's important to consider these before one starts asking the laboratory, and also at the same time reassess the thyroid status of the patient. Are they hypothyroid, euthyroid, or hyperthyroid? Because only when you can determine where you think the abnormality is, can you speak to the laboratory and ask them to exclude thyroid hormone or TSH assay interference. And only when that's been done should we go looking for the rare causes, genetic or acquired disorders, which we have not discussed today, but which would often need referral to a specialist centre. I'm going to complete that by saying thank you very much for your attention.